Gastro-oesophageal reflux, GOR, is a normal physiological process that usually happens after eating in healthy infants, children, young people and adults. In contrast, gastroesophageal reflux disease, GORD, occurs when the effect of GOR leads to symptoms severe enough to merit medical treatment. GOR is more common in infants than in older children and young people, as shown by the effortless regurgitation of feeds in young babies. In clinical practice, it is difficult to differentiate between GOR and GORD, and the terms are used interchangeably by health professionals and families. There is no simple, reliable and accurate diagnostic test to confirm whether the condition is GOR or GORD, and this, in turn, affects research and clinical decisions. Furthermore, the term GORD covers a number of specific conditions that have different effects and present in different ways. This makes it difficult to identify the person who genuinely has GORD and to estimate the real prevalence and burden of the problem. Nevertheless, regardless of the definition used, GORD affects many children and families in the UK who therefore commonly seek medical advice and, as a result, it constitutes a health burden for the NHS. Generally, experts suggest that the groups of children most affected by GORD are infants who are otherwise normal, children with identifiable risk factors and pubescent young people who acquire the problem in a similar way to adult patients. The two other specific populations of children affected by GORD are premature infants and children with complex, severe neurodisabilities. In this last group, the diagnosis is complicated further by a tendency to confuse vomiting with or without gut dysmotility with severe GORD. In addition, for the child with neurodisabilities, a diagnosis of GORD often fails to recognize a number of distinct problems that may coexist and combine to produce a very complicated feeding problem in an individual with already very complex health needs. For example, a child with severe cerebral palsy may be dependent on enteral tube feeding, have severe chronic vomiting, be constipated, suffer marked kyphoscoliosis, possess a poor swallow mechanism and be unable to safely protect their airway, resulting in a risk of regular aspiration pneumonia. This guideline focuses on symptoms of and interventions for GORD. Commonly observed events, such as infant regurgitation, are covered, as well as much rarer but potentially more serious problems, such as apnea. Where appropriate, clear recommendations are given as to when and how reassurance should be offered. In contrast, advice is given to healthcare professionals regarding when investigations should be considered or treatments are indicated. Finally, it is emphasized that other, and on occasion more serious, conditions that need different management can be confused with some of the relatively common manifestations of GOR or GORD. These warning signs are defined under the headings of red flags, along with recommended initial actions. The focus of this guideline is primary and secondary care while dovetailing with the likely investigation and management that could be expected when a referral to tertiary care is indicated. Where a particular area of specialist interest is not covered as expected, this is likely to be because of the very specific focus of the guideline or due to a lack of evidence or consensus. This guideline is specifically about GORD in children. It is not a detailed guideline on complex feeding issues, a protocol for an approach to the vomiting child or a textbook for the tertiary specialist. In addition, where there is a perceived absence of evidence or a lack of consensus, then other specific areas may appear neglected, but when this occurs an effort has been made to make detailed and prescriptive research recommendations.